Bismillahirrahmanirrahim. I am Shaila Riaz from the final prof and my roll number is BP1650208. The topic of my assignment is basically heparin sodium, where I have to provide the essential drug knowledge being a pharmacist. So heparin sodium is basically an anticoagulant. It's the heterogeneous mixture of the sulfated mucopolysaccharides. Basically, J. McLean discovered the heparin in 1914 when he was second year medical student. It was extracted, this heparin was extracted basically from the liver of the dog. That's why it is called as heparin, as hepa means liver and rin means protein. It's anticoagulant, which means that definitely it prevents the coagulation of the blood. And it's not the direct thrombin inhibitor, rather it's indirect thrombin inhibitor, and we can say this like as it binds to the antithrombin 3 first, and then they both together inhibit the thrombin factor 10A and 9A. So it's basically the indirect thrombin inhibitor. And we have furthermore different types of the heparin: unfractioned heparin, that is high molecular weight heparin; low molecular weight heparin; fondaparinux. And fondaparinux is basically the synthetic heparin, it's not the natural one. Low molecular weight heparins as compared to the high molecular weight heparins are basically much safer, and they have much more increased bioavailability and increased due to increased half-life and other pharmacodynamic factors. Low molecular weight heparin requires the less frequency of dosing, right? And low molecular heparins include enoxaparin and dalteparin. The available forms of the heparin sodium in Pakistan are like heparin, multiparin and pine. We have the doses are also mentioned here, and the price is also mentioned. With respect to the price, the pine is much more better. Well, the indications, the conditions when the heparin is required involve deep vein thrombosis, pulmonary embolism, coagulopathies, and prophylaxis. Route of administration. Route of administration basically depends particularly upon the indication that why we are giving the heparin. For DVT and PE, the loading dose is followed by IV infusion, and then further doses plus the route of administration is mentioned here. And like for prophylaxis, 5,000 units 2 hours before surgery, subcutaneous injection, and then 8 to 12 hours for 7 days. During pregnancy, 5,000 to 10,000 units every 12 hours. And for prevention of the mural thrombosis, 12,500 units every 12 hours for 10 days. Precautions. By precaution I mean the conditions where we must take heparin very carefully. It includes that intramuscular injection is not always favorable in case of the heparin sodium, so we must be careful regarding all these conditions. Like it's good for pregnancy as it does not crosses the placenta, and acute nephritis, severe hypertension, bacterial endocarditis, it must not be given. And contraindications include the severe thrombocytopenia, uncontrolled bleeding, suspected intracranial hemorrhage, shock, severe hypotension. These are all the conditions in which the heparin is, when given, the bleeding may get worsened, and the person or we can say the risk of the mortality will be increased. Side effects are very much like I have written here with respect to the systems like CNS, fever and headache, severe allergic, vasospastic reactions and shock. Okay. Now interaction and toxicity. Aspirin, it interacts with the aspirin. When heparin is given along with the aspirin, there is increased risk of hemorrhage, and when it is given along with the warfarin, it may prolong PTT in patients receiving heparin. Heparin may prolong PT in patients receiving warfarin. Toxicity. As heparin inhibit the coagulation, obviously the higher toxicity related to it will be bleeding. So bleeding and reversible alopecia may also occur. Heparin actually accelerates the clearing of postprandial lipemia by causing the release of the lipoprotein lipase from tissues. HIT, heparin induced thrombocytopenia, and by this 1 to 4% of the individuals that are being treated with the heparin are affected. Skin necrosis are also there because of the depletion of the vitamin K dependent anticoagulant protein C. Alternatives of heparin are there like other anticoagulants, warfarin and fondaparinux, enoxaparin, and these all. Now we are about to see the case study that involves heparin sodium as a treatment. So we have the case here. The subjective from the case is that the person is a male and his age is 52 years. His weight is 62 kg, and symptoms that is that swollen left leg. Medical history that he had been on co-amylo flues 6 months earlier for mild breathlessness on exertion. In objective, when that person is physically examined, it was observed that he has been suffering from the shortness of breath with regular pulse and raised jugular venous pressure, left cleft inflamed, and it was painful to touch also, left thigh swollen, pitting edema on the left leg. Chest X-ray basically showed that there is a fluid retention, and calf circumferences were measured, and these are mentioned here. Further lab test and that included 2-level Wells score. It showed the presence of DVT, and proximal vein ultrasound. It further confirmed the DVT. So that person was assessed or diagnosed to have a left DVT and mild ventricular failure. So its treatment was planned in such a way that he was admitted into the hospital and he was prescribed co-amyloflues tablets 5/10 41 every morning, and tenzapirin injection 14,000 units subcutaneous once daily, warfarin tablet loading dose to be given over 3 days, and brufen for pain. And there was a follow-up treatment also, that warfarin follow-up plan also, that the warfarin activity monitoring should be planned with INR done on day 4, and then this INR should be conducted or done on daily basis, and then further this testing interval should be increased gradually. And furthermore, other drugs and dose adjustment, it could be done by observation that depend upon the laboratory testing and patient's health conditions. And these are the references from where I have taken my material. Thank you so much.